Down syndrome is certainly the trisomy that you're most likely to see during your training, but there are a couple more trisomies that are important to keep in mind. Trisomy 18, also called Edwards syndrome, and trisomy 13, also called Patau syndrome. These two action-packed trisomies are now available to rent on Chromosome Plus, the newest competitor to enter the TV and movie streaming space. It's a beautiful day outside, but these girls are too busy fighting over the remote to notice. Throughout this sketch, we will be making references back to similarities in the workup of trisomy 21, so let's bring that sketch back as one of the available movie options. Add that to my watch list of must-see films that I'll never see. The Chromosome Plus fatigue is real. Trisomy 18, also known as Edwards syndrome, is associated with dysmorphic facial features, minor and major congenital anomalies, severe developmental delays, and intellectual disability. Edwards syndrome will be represented here by the hottest action movie out right now, Edwick 3, Rocker Bottom. It is the second most common trisomy in live births, seen in 1 in 8,000. Remember that Down syndrome is the most common. Edwards syndrome is seen 3 times more commonly in females than males, hence the female assassin joining Ed Wick on his latest excursion. Trisomy 13, also known as Patau syndrome, is associated with severe congenital malformations like eye abnormalities, CNS defects, and midline facial malformations, as well as postaxial polydactyly and intellectual disability. Patau syndrome will be represented here by the Patau Squad movie poster. Patau Squad, assemble! Like with Edwards syndrome, Patau syndrome is seen more commonly in females, hence the female superhero lead. In the vast majority of cases, both Edwards and Patau syndromes are caused by a trisomy event, having 3 complete copies of either chromosome 18 in the case of Edwards syndrome or chromosome 13 in the case of Patau syndrome. Like Down syndrome from trisomy 21, these trisomies are most commonly caused by maternal meiotic non-disjunction, represented back at the junction bar located downtown in the Down syndrome sketch. Also similar to Down syndrome, Edwards and Patau syndromes can less commonly be caused by 2 other types of chromosomal changes during fetal development. Some patients affected with Edwards or Patau syndrome have underlying chromosomal mosaicism caused by mitotic replication errors in early fetal development. This mosaicism is represented by the mosaic pattern on the junction bar sign. Some cells will have the normal chromosome 18 or 13 complement, and others will have trisomy 18 or 13. As with the other trisomies, the percentage of mosaicism does not correlate with the clinical phenotype. Alternatively, Edwards and Patau syndromes can result from a translocation event, which generally occurs de novo, but less commonly can be hereditary from a parent who is a carrier of a balanced translocation. Translocations occur when one arm of either chromosome 18 or 13 attaches to another chromosome during gamete production, leading to extra chromosome 18 or 13 material in the fetus. Notice the transit station sign back in the Down syndrome sketch where one of the chromosomes is extra long? That generally doesn't bode well. Chromosome 13 specifically, like chromosome 21, is one of the acrocentric chromosomes that can stick together during gamete production, causing a special type of translocation called a Robertsonian translocation. Note the Robertson Station subway stop in the King Kong poster. Of the 3 trisomy syndromes, 21, 18, and 13, the incidence of disease-causing translocations is actually highest in Patau syndrome. Unfortunately, both Edwards and Patau syndromes are associated with a very poor prognosis because of the severity of underlying congenital anomalies and health complications. The majority of affected fetuses die in utero, around 95% for trisomy 18 fetuses and 60% for trisomy 13 fetuses. This high miscarriage rate is represented by the fallen-over baby carriage. Of those babies with Edwards or Patau syndrome that survive to be born, most die within the first month. Note the 1-month expiration date for both movies. Fewer than 10% of these infants survive past their first year. Survival into school age is possible, but those children uniformly show severe intellectual delay, and most have a whole slew of other medical comorbidities. We'll discuss more on this later. Given the poor prognosis, it's important to recognize Edwards and Patau syndromes when you see them. In many cases, it's possible to make the diagnosis prenatally. When you review the prenatal history, look out for a few key things. Maternal age is definitely important, since advanced maternal age, which is defined as age 35 and over, increases the risk for all trisomies, including trisomy 18 and 13. The gray-haired mother from the King Kong poster depicts this. You'll also want to look up the results from mom's first and second trimester screening tests. These screens look at the fetal nuchal translucency measurement on ultrasound and measure various hormone levels in the maternal blood to evaluate for patterns that might suggest an underlying condition, like Edwards or Patau syndrome. Check out the Trisomy 21 sketch if you want to learn a bit more about these prenatal screening tests. These days, a lot of women are also getting an NIPT or NIPS, which stands for non-invasive prenatal test or screen. This nifty tool offers a much higher positive predictive value than serum screening because it actually analyzes fetal DNA that is free-floating in the maternal serum during pregnancy. Remember, this is still just a screen, but it's a pretty good one. While you're reviewing the prenatal history, take a peek at the prenatal ultrasound results, represented by the pregnant lady holding the ultrasound bullhorn. There are a few findings on prenatal ultrasound that are commonly seen in association with Edwards or Patau syndromes. We'll review some findings for Edwards syndrome first. Choroid plexus cysts, noted by this fancy plexus car keychain, can be a normal finding in isolation, but if seen with other abnormalities, can be concerning for Edwards syndrome. IUGR, or intrauterine growth restriction in the setting of polyhydramnios, is a very unusual combination and is concerning for Edwards syndrome as well. These are represented by the restricted warning and the overflowing cup of fluid. Additional prenatal ultrasound abnormalities may be present that are less specific but still concerning for Edwards syndrome, including limb abnormalities, nuchal thickening, cystic hygroma, brain abnormalities and neural tube defects, strawberry-shaped calvarium, facial changes like micrognathia or clefts, cardiac and GI abnormalities, urologic malformations, and a two-vessel umbilical cord. Findings concerning for Patau syndrome on prenatal ultrasound include intrauterine growth restriction and cerebral malformations such as holoprosencephaly, represented by the slick holopro goggles, which is due to a failure of the forebrain to divide properly during embryonic development. If the first and second trimester screens show an increased risk for Edwards or Patau syndrome, and/or you see concerning abnormalities on prenatal ultrasound, then you may want to pursue more formal diagnostic prenatal testing. Think back to the downtown scene. Chorionic villus sampling can be performed in the first trimester, between 10 and 12 weeks gestation, represented by the corn samples at the first farmer's market table. Alternatively, an amniocentesis can be performed in the second trimester, between 16 and 20 weeks. Amniocentesis is represented by the amnio apple juice samples at the second farmer's market table. In either case, a karyotype can be performed on cells from the sample to determine if the fetus is affected with trisomy 18 or 13, or any other trisomy for that matter. Depending on the severity of congenital anomalies, some families may elect to terminate the pregnancy after a diagnosis of Edwards or Patau syndrome has been made. Rarely, a baby is born who was not prenatally diagnosed. Either the mom had no prenatal care or the parents declined prenatal testing. In that case, there are a few clues on the newborn physical exam that might get you thinking about one of these trisomies. Doing a detailed dysmorphology exam of the infant will be a critical step in your evaluation. Edwards and Patau syndrome share some physical exam findings, but each syndrome has some characteristic and unique findings as well. Let's start with the features that are similar in both trisomy 18 and trisomy 13. Babies with either Edwards syndrome or Patau syndrome are often small for gestational age, also called SGA, kind of like that smaller baby doll. They also generally have dysmorphic facial features, like microcephaly, depicted by the microdoll head, micrognathia and a small mouth, represented by the microdoll chin, and small, low-set ears, often with structural changes. represented by the low ear looking beads on the doll's hair. Babies with Edwards syndrome classically present with rocker bottom feet, hence the little rocking chair over here. But you may also see this type of foot deformity in Patau syndrome as well. Okay, now let's talk about the more unique physical exam findings of each syndrome. Babies with Edwards syndrome often have a prominent occiput, or in this case a prominent occipital bun on the female assassin. Other classic findings on exam include clenched hands with overlapping second and fifth digits and hypoplastic nails. See how Ed Wick clenches his fist in a unique way when he holds his gun? Lastly, patients with Edwards syndrome are typically hypertonic, represented by the female assassin's hypertonic grip on her gun. Let's switch back to the Patau squad. There are 3 classic findings associated with Patau syndrome. The first is significant eye abnormalities, such as microphthalmia, represented by the tiny laser goggles, cyclopia, represented by the single eye of the evil chromos, or anophthalmia, colobomata, which are defects where parts of the eye are missing, or other eye abnormalities may be present as well. The other 2 classic exam findings include a cleft lip or palate, represented by Chromos's cleft helmet, and postaxial polydactyly, meaning extra digits after the pinky, depicted by Chromos's all-powerful polydactyly gauntlet. A range of other abnormalities may be seen on physical exam as well. Other craniofacial malformations, such as cutis aplasia or focal absence of scalp skin, absent philtrum, or a sloping forehead, are often noted. Additional extremity abnormalities are also common in Patau syndrome. Hand abnormalities may include a retroflexible thumb, syndactyly, radial aplasia, transverse palmar crease, and hyperconvex narrow fingernails. Foot abnormalities may include a sandal gap, hypoplastic toenails, polydactyly, prominent heel, clubfoot, or rocker bottom feet. Genitourinary abnormalities are also common, most notably hypospadias and cryptorchidism in males, and a hypoplastic labia minora in females. Note the concentration of laser beams around the villain's groin area to represent these GU problems. Dang, this is PG-13? If you see some or all of these exam findings, you'll definitely want to order a karyotype to confirm the diagnosis of trisomy 18 or 13. Most of the physical exam findings in Edwards syndrome are pretty unique, but there can be some overlap with a few other syndromes, like Charge syndrome and distal arthrogryposis, which you can keep on your differential. What about any other possible differential diagnoses for Patau syndrome? Other chromosomal abnormalities can be associated with some of the physical exam findings of trisomy 13, but not commonly all of them. So a karyotype will weed these out and confirm your diagnosis. Check out the differential diagnosis menu to learn more about these differentials. So, now that the prenatal history, your exam, and the karyotype results are all consistent with the diagnosis of either Edwards or Patau syndrome, what should you do next? The management plan for these 2 syndromes will be depicted around the parents, who have a plan to drag these kids away from the TV. Due to the complex nature and often multi-system involvement of both Edwards and Patau syndromes, meeting with the parents and a multidisciplinary team consisting of social workers, genetic counselors, medical providers, etc., to discuss the physical exam findings, lab results, diagnosis, and prognosis is important. Ideally, this discussion should start prenatally, before the baby is born, to decide on the pregnancy and postnatal care plan. Once the infant has been born, you can review what counseling has already been done with the family and discuss the baby's physical exam findings and imaging results. For those infants not diagnosed prenatally, the team should meet with the family to discuss the diagnosis, associated complications, and prognosis to decide on the best plan of care for the infant. Make sure to allow time for the family to digest this new, unexpected information and begin to process and grieve. During the course of these discussions, families often ask about recurrence risk for future pregnancies. In the case of trisomy 18 or 13, the recurrence risk is about 1%, or the maternal age-related risk, whichever is higher, just like the 1% recurrence risk in the Down syndrome sketch. In the less common setting of Edwards or Patau syndrome being caused by a translocation, you should order parental karyotypes to see if one of them is a carrier, which would increase the recurrence risk over 1%, which is depicted by the greater than 1% graffiti by the transit station. Discussing the diagnosis and prognosis in these infants is often a lot of information to take in at once for the parents. You can provide the family with appropriate references and resources and inform them about the option of joining disease-specific support groups both locally and online, which can help provide a sense of community. Beyond counseling the parents about what to expect, there are some aspects of initial and ongoing management that you should remember as you care for the infant. Many families choose to minimize interventional or painful procedures due to the poor prognosis of Edwards and Patau syndromes. Management for both Patau and Edwards syndromes can be pretty similar, depending on what congenital anomalies are noted. Initial management is focused on stabilizing the baby and evaluating for common congenital anomalies. Many babies with Patau syndrome and more than half of Edwards syndrome babies will have congenital cardiac anomalies, so it's important to get an echocardiogram on all of these infants. An echocardiogram is represented by the heart-shaped bullhorn held by the enthusiastic dad. The most common cardiac abnormalities in both Edwards and Patau syndromes are a ventricular septal defect, denoted by the excessive shirt opening over his chest as he stands next to the open heart door, or a patent ductus arteriosus, denoted by the patent air duct on the ceiling. Kids with Patau syndrome may also be born with dextroposition, or an atrial septal defect, or ASD. You'll also want to keep in mind the potential for underlying GI malformations in both of these trisomy syndromes, represented by the mom's fanny pack that looks an awful lot like intestines. GI anomalies are present in 75% of infants with Edwards syndrome. The most common abnormalities are malrotation, depicted by the twisted, malrotated yo-yo string, Meckel's diverticulum, represented by the checkers board, and omphalocele, represented by the elephant seal toy. While an omphalocele will be obvious on your initial exam, you can screen for Meckel's and malrotation by reviewing normal feeding and stooling patterns, as well as discussing signs of feed intolerance and other signs of GI obstruction, inflammation, or bleeding. Additionally, both Edwards and Patau syndromes can be associated with renal abnormalities, such as cystic or horseshoe kidneys, so getting a renal ultrasound is a good idea in these patients. The horseshoe clasp on the babysitter's kidney bag and her cystic kidney balloon should remind you to screen for these kidney problems. Babies with Patau syndrome may also have hydronephrosis. Seizures are another potential comorbidity for patients with Edwards and Patau syndromes, so be sure to monitor for any abnormal movements or other seizure-like activity. Many patients with Edwards and Patau syndromes have respiratory abnormalities, represented by the obstructed kazoo. Wow, Mom is really pulling out all the stops to distract those girls from the TV. These pulmonary problems may include upper airway obstruction, aspiration problems, central apnea, and more. Respiratory failure is a common cause of death, and many of these kids need respiratory support. Patau syndrome also has a few unique management considerations. Brain imaging may be important to screen for holoprosencephaly or other CNS abnormalities. Additional genitourinary abnormalities may be seen, such as a bicornate uterus in females, so consider further evaluation as appropriate. Virtually every body system can be affected in these patients, so they should be carefully evaluated to determine what further imaging or workup is indicated. For those babies with Edwards or Patau syndrome that do survive past 1 year, they face significant ongoing health complications and challenges, including severe intellectual disability, represented by the Falling IQ book. Patients with both syndromes often need feeding support, and many infants with Patau syndrome struggle with failure to thrive. Sadly, since most patients with Edwards and Patau syndromes don't survive past their first year of life, it's a good idea to open the discussion about potential palliative care involvement from an early stage. The severity of malformations is different for every child, so the care decisions should be tailored for each baby and family. Cardiac arrest, cardiac failure, and respiratory problems are the most common causes of death in these patients. Pal, the movie, is definitely a tearjerker. Let's flip through the selections one more time and review our options. Edwards syndrome, or trisomy 18, and Patau syndrome, or trisomy 13, present with a constellation of congenital abnormalities leading to a poor prognosis. Most of these infants die in utero, and those that do survive generally do not survive past the first year of life. Prenatal serum screening tests for Edwards and Patau syndromes include a first trimester triple screen, second trimester quad screen, and a NIPT or NIPS cell-free DNA test on the maternal serum. You may also see concerning findings on prenatal ultrasound. Formal prenatal diagnosis is made via karyotype testing from CVS or amniocentesis. Both Edwards and Patau syndromes are more commonly seen in female infants, and the risk increases with advanced maternal age. Some clinical features are common between Edwards and Patau syndromes, including IUGR on prenatal ultrasound and born small for gestational age. Both syndromes are associated with micrognathia and microcephaly, small, low-set malformed ears, and rocker bottom feet. Edwards syndrome specifically classically presents with choroid plexus cysts, IUGR and polyhydramnios on prenatal ultrasound, and clenched hands with overlapping second and fifth fingers, prominent occiput, hypertonia, and rocker bottom feet on postnatal exam. Patau syndrome, specifically, classically presents with significant eye abnormalities like microphthalmia or anophthalmia, a cleft palate, and postaxial polydactyly. Watch out for other craniofacial, extremity, and GU abnormalities too. These infants may also have significant cerebral malformations like holoprosencephaly, other craniofacial abnormalities such as cutis aplasia or sloping forehead, a variety of extremity abnormalities, and GU defects such as cryptorchidism, hypospadias, hypoplastic labia minora, or a bicornate uterus. Further workup for both Edwards and Patau syndromes includes an echo to screen for congenital heart disease, including septal defects or a PDA, monitoring for GI anomalies like malrotation, Meckel's diverticulum or omphalocele, and a renal ultrasound to screen for renal abnormalities like polycystic kidneys or a horseshoe kidney. Infants with both syndromes commonly have respiratory and feeding problems and are at a higher risk of seizures. In the unlikely event that they survive past 1 year of age, they have severe intellectual delay. On second thought, let's see what other movies are available. Seen that one 20 times? Too sappy. Too cerebral. Bloodpool is out? Ooh, nice!